and welcome to Module 4, Lecture 1 for Community Health Advocacy and Social Movements. In Week 7, we'll be identifying strategies to manage aspects of patient care, assessment, planning, coordination of service, patient education and advocacy, clinical monitoring, and outlining preventive care programs to motivate individuals to improve their health status. And this is more of a project, and we'll get into that at the end of the lecture. Your readings and media, the Evans article talking about care coordinators. You have 3 videos for the PNHP Western Washington, the seminar. I would suggest watching the first 35 to 40 minutes, and if you don't have time for the last about 20 minutes, you can skip it. It's just a question-answer part. But the actual seminar, it's a discussion about case studies of cultural care managers or navigators, and it's really interesting. Harborview Hospital in Seattle has this program about health advocates. So, and then all these videos are interesting. So we'll start with managing patient care. So according to the Evans article, a measure being implemented for cost saving and improving patient outcomes and clinical care is the introduction of care coordinators or care navigators into the health system. Traditionally, care navigators are the gatekeepers, physician assistants, nurse practitioners, primary care doctors, and those are the people right now coordinating care for patients. And so the Evans article suggests transferring that duty and responsibility and skill set to other providers who have less clinical training and who would therefore be less expensive to employ, to give partial responsibility or maybe full responsibility of patient care navigation. So this might be medical assistants, community health workers, other health providers. And we have a video about community health workers, what they do and their role in patient support and education. We actually have, I know we have one in this class, we might have more than one. So basically transferring that knowledge and skill that we saw in the textbook, Body and Soul. Many of you wrote beautiful discussion posts about this aspect of transferring medical knowledge to other types of providers as a liaison between the doctor and the patient, or between the health system and the patient, and having that health provider in between who can actually support a patient and provide education, provide a lot of the things a patient needs to get better. So ideal patients for care coordination. So ideally, it would be safety net patients, people on Medicare and Medicaid. So Medicaid, it's low resource patients, low income patients. Medicare is elderly. So these are really good candidates for care coordination in terms of having an advocate or somebody to help out. At-risk patients are also very, according to Evans, very likely to not get all the care they need if they're likely to be hospitalized or if they're post-hospitalization and they're recovering. A care coordinator could be the difference between that person getting readmitted or recovering well and going home and staying home. So at-risk patients, low resource patients, so people without transportation, we saw that in the Colorado video, might have been in your other class. Low income patients, so again, safety net, or maybe not. Maybe they have no insurance, or maybe they have company insurance, which is not that great, or they don't have a car, or somehow they're not able to manage the care that they need. Um, Language barriers is a big one, and we'll see that in the Harborview, the PNHP seminar, and multiple morbidities. So this is a majorly at-risk population. If you think about a patient who has a complex health condition, maybe they have diabetes and depression and cardiovascular issues, so 2 to 3 or more health conditions at the same time. That's someone who may be able to coordinate their own care if they had one condition, but having multiple makes it all the more complicated. Primary care and care management. We talked about this a little bit in your previous lectures, the gatekeeper model, especially in managed care organizations. But the Evans article discusses the shift away from primary care providers to health providers with less training, as we were discussing on the previous slide, to be care coordinators. And this is a global shift. So if you watch the PBS clip of Dr. Carey, um, people in low resource countries and low resource health systems are also making that shift because it costs more to have your physician or nurse practitioner have their time billed for patient education, support, organizing treatment with a referral or consultation with the referral or with a specialist. So all for a doctor or a high skilled provider to do that work is sometimes too expensive, both here in the US, but maybe it's just not possible in places where there's brain drain and the doctors are leaving. And there's many reasons. Dr. Carey showed the interviews of people why they're leaving. It's just sometimes sheer frustration of a doctor not having the supplies they need. Maybe there's no clean water in the area. Maybe the electricity goes off. Um, Maybe their prescriptions run out in the whole pharmacy and hospital in the catchment area, and they don't have any medicine to give. So being a doctor in a low resource area can be very frustrating, and many of them leave for that reason, not to mention the pay and the compensation for being a doctor in a low resource area. So aside from that, why might the transfer of skills and knowledge from more highly trained to less trained clinical care workers be important in community health? And so this question, you did explore it. People gave amazing, excellent responses to the discussion about this topic, about transferring knowledge and skills to volunteers and to lower trained health providers. And what have you learned from our textbook to suggest that this is a good idea? So paradigm shifts. There are two major paradigm shifts I'd like to address in this skill shifting. One of them is value-based payment, and organizations implementing a transition to using care coordinators cannot bill using fee-for-service model because counseling, care navigation, maybe they're calling their patient, maybe they're going to their patient's home and helping them get to the hospital. So how do these ways of supporting a patient translate into billing? They really don't if it's just a direct fee for a direct service. So there's a service provided and according to a billing code, money is charged for that service. So rather than that, the big paradigm shift here is value-based payment. Health outcomes. Are the patients getting better? Are they taking less medication? Are their vital signs and health outcomes improving on follow-up visits? These are a different kind of way of billing, and it's very different from the current system. Job responsibilities is the other paradigm shift, and that's pretty much mostly a mental shift, both for providers, doctors, nurse practitioners, PAs, who were originally gatekeepers and care coordinators for their patients, and transferring that responsibility to MAs, community health workers, nurses, social workers. And that might be difficult for primary care providers to give that responsibility. Maybe it's something they love to do and they don't want to give it up. Maybe it's something they don't have time for and they're excited to give it up. And on the reverse end of it, maybe medical assistants already have a big patient load and they have to do their intakes and blood pressure checks and take care of the patients as they come in. And then they also have this extra role on top of what they do. So it might be a burden to do this extra job and be paid the same, or it might be a big privilege. It might be a promotion to be able to do this work. It might be a privilege for people who want to connect with patients and support them on that level. So this is a big mental shift for both people giving up the care coordination and people assuming this new responsibility. As we saw in the PBS NewsHour, maybe they have to give up. I mean, maybe they have to train nurses and other providers to do a lot of care coordination because the doctors are leaving. And as they explained in the video, a lot of it has to do with infrastructure, with not having enough medicine or supplies or electricity or water, just the sheer frustration that doctors in low-resource countries and in low-resource hospitals have to face on a daily basis when treating patients and not having adequate medicines or whatever they need to treat the patient. So this video that we saw of Dr. Carey's organization is increasing self-respect and respect for the profession of nursing by improving teaching hospitals for nurses, giving them more comprehensive training, basically bringing them up in the ladder of training, clinical training, because of the huge shortage of primary care providers. And that's even true in the United States. Even here, where we have many more doctors and nurse practitioners and PAs, there's still a shortage of PCPs. So this skill transfer is very important to save costs especially in low resource countries, but even in low resource clinics and outpatient facilities in the US itself. So next we'll be focusing on part 2 of this lecture. We'll be talking about patient education and advocacy. Please watch the Physicians for National Healthcare Western Washington video if you haven't seen it about cultural care navigators. There are 3 case studies. It's a great video, it's a seminar, and so we'll start on that in part 2 of this lecture. And please check out the PBS, this PNHP video, and the Evans article if you haven't seen it yet. So see you next time.